The U.S. does not have a national cancer registry, everybody. We have a bunch of state registries. Some of those registries do collaborate and share information. The issue is the registries that do exist typically do not report cancer by occupation. So we cannot get our arms around the potential work-relatedness of the health outcome, given the sort of current way that the state registries collect information. What we're trying to set up is a way to make what currently is an invisible risk visible.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Dr. Melissa McDiarmid, Professor of Medicine and Epidemiology and Public Health, and the Director of the Division of Occupational and Environmental Medicine at the University of Maryland School of Medicine in Baltimore, Maryland. Melissa is one of the visionaries who has worked for years to develop a national hazardous drug exposure database. As a reminder, this episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome and thanks so much for joining us today, Melissa.
Very happy to be here with you. I'd like to also say I'm happy to be a proud honorary member of the Oncology Nursing Society.
Wonderful. Absolutely. Well, we love to hear that as well. So let's begin our episode today with a discussion and an overview of what is this Hazardous Drug Safety Center and Registry and what prompted its development.
The Hazardous Drug Safety Center is a group of faculty and staff at the University of Maryland School of Medicine's Division of Occupational and Environmental Medicine. And we have research work and outreach activity that focus on hazardous drugs. The prompting of this has really taken place over several decades because despite the name hazardous drugs, using air quotes, there really still are questions about what that means. In other words, the hazardous nature of them and whether significant exposure is still taking place. This because there have been many professional guideline documents that have come not only from ONS, but ASHP, NIOSH, OSHA, and many of them published originally 30 years ago. And so there is this question about whether there is still a hazard. Maybe there was years ago, but is it enduring? Unfortunately, we think it likely is because there's variable adherence to these existing professional standards. Given that context, we come to this from an occupational health perspective. That is, we're looking at the severity of a potential hazard, these drugs in this case, and asking whether there is evidence of exposure. As you all know, the term hazardous drug, it was really coined originally by ASHP and NIOSH adopted it in the 1994 first NIOSH alert. There were 6 characteristics of a drug that could be a feature that would say we should handle the drug as hazardous. And these are, as you all know, probably by heart, carcinogenicity, mutagenicity, reproductive or developmental toxicity, acute toxicity, such as the agent could be caustic if it gets on your skin. And then finally, if it's a drug that has features of another recognized hazardous drug, it should be handled as hazardous, kind of until proven otherwise. And this would be, for example, an IND drug that maybe comes into your organization. So that's the hazard. And then given that we're observing and we know people in their oncology practice are handling potentially hazardous agents, the question becomes, is there an evidence of exposure? We've got, again, 25 years of evidence showing indeed there are both indirect measures of exposure, such as looking at a contaminated work environment, like the wipe sampling that people are doing now in pharmacy and in nursing areas, but also pretty direct measures. I'm sure a number of you have heard about or heard people present about nurses or pharmacy colleagues actually having hazardous drugs in their own urine. Obviously, this implies there'd been uptake into the body from them handling the drugs in the workplace. Given there are these health concerns, this is sort of the whole context or the backstory for why we established a hazardous drug safety center. To get at why we set up a registry, it's really to try to document the hypothetical risks that pharmacy and nursing professionals could be accruing as a result of handling these drugs. The registry is going to be a little different than probably the registries you all have heard of. Typically when we're in school, we hear about disease registries. For example, in the old days, there'd be people are enrolled who have a certain infectious disease, for example, so that public health agency can keep track of this cohort of people that share the same disease. Well, more recently, public health advocates have set up what we're now calling exposure registries. That is trying to keep track of a group of people who share the same exposure. A really good example of that might be you all maybe heard about the 9/11 registries that have set up for people that were, near the Twin Towers on 9/11. And there's been a lot of following forward of people that had inhaled those dusts and such like. And so here we were thinking that in order to answer some of the unclear questions about health risk, we would set up an exposure registry, in this case for oncology personnel who handle the drugs. And this would then create a cohort that we could ask questions to. For example, we could try to characterize whether there is a cancer excess in this group, or to characterize the reproductive abnormalities in excess that people are experiencing.
Absolutely. Well, and I think even in your introduction, just mentioning or highlighting, like there has, even despite all the work that's been done for hazardous drug handling, there is still variable sort of uptake in those precautions. And so it is just, I think, curious. I think back to my own sort of initial training in oncology, where it's scary to even think about how we handled the drugs 20 years ago, whether that was out of just not knowing or just other things to think about. Like there was not, in my perception, it was like there wasn't as much of an emphasis on, hey, these drugs are potentially dangerous. Let's be careful how we handle them. And so to think even through sort of 10 years ago, even when certain sites were maybe not even wanting to take on wearing the PPE and doing all the precautions, that we haven't done it before. Why start now? So it's to where we are now, where I feel more assured that sites recognize the risk and take precautions seriously. But like you said, there's still variable uptakes in how we handle these drugs. And so excited to learn more and hear more about this registry and how we can encourage our members to consider joining once they learn more. So let's talk a little bit about that. What would you say are the main objectives of the registry? And can you talk a little bit about, is it focused on exposure tracking, long-term health outcomes, maybe policy development to kind of help support what we're finding, or is it something else?
It's probably all of those things. Let me start by saying it's a data set we hope to establish based on people participating and completing a survey. And we can then query the survey as we move forward with higher numbers of people participating. We'll have a population large enough to be able to see any potential signals, such as an adverse health outcome or an adverse reproductive outcome, but from a population perspective. The frustrating part, and maybe a shock to the colleagues in oncology of all places, is that the U.S. does not have a national cancer registry, everybody. We have a bunch of state registries. Some of those registries do collaborate and share information, but the issue is that the registries that do exist typically do not report cancer by occupation. So many people that are listening to this podcast perhaps already have had a cancer, and it's been reported within the state where that cancer was diagnosed. But nobody wrote down it's an oncology worker, Mary Jane Smith, who has this cancer. So we cannot get our arms around the potential work-relatedness of the health outcome, given the sort of current way that the state registries collect information, let alone we don't have that unifying power of a national registry. So there have been some studies, but years ago in countries that do have national registries that has suggested or have documented higher risk of certain cancers, typically leukemias and lymphomas, in oncology nurses or physicians, because in some countries, the physicians in those days were giving the drugs. So there is like a lot of face validity, we'd say, to needing to pursue the questions that we have about these hazards. That's kind of what we're trying to set up, is a way to make what currently is an invisible risk because of the lack of a national registry. We're trying to make it visible and just really see if there is one. I'm sure we're all going to be happy to find if there isn't something like that.
Right, exactly.
Right.
We will be pleasantly surprised if that is the outcome.
But right now, we can't speak with any surety that there isn't a problem.
It is shocking to think we don't have a national registry, and also that, we know there are certain occupations and fields that if they do regularly work with certain chemicals or in certain environments, we acknowledge that those occupations have a higher risk of cancer development. And it's just funny to think that have we ever looked inward and realized we are also one of those occupations, or do we have the data to show it? And that's exactly what you're speaking to here, is that this is trying to create some visibility and an understanding of, is there an increased risk, or are we taking precautions that are helping to keep that mitigated, or at least as minimal as possible?
Exactly right. Let me just tip my hat to what you already mentioned, Jamie. This is hard to fathom. In fact, I've written about this, that it's sort of counterintuitive that the healthcare industry, whose mission itself is care of the sick, is a high hazard industry for the work there. We typically think about the risk as being from infectious diseases. And certainly we've all lived in our practice lifetime through some examples of that. Even before COVID, some of us were doing preparation for Ebola and this sort of thing. So we're kind of used to that. But, the hazards that you kind of grew up with, we've routinized or normalized handling group 1 IR carcinogens, human carcinogens, which a number of these drugs are, is just something we do every day. Well, it is, but we have to do it with respect and with care every day. And I think sometimes in that routineness of it, we sort of have lost sight of that, really the vigilance that we need to maintain.
So how do you envision this registry helping to improve the safety for nurses who handle hazardous drugs?
I think, for one thing, just the process, like things we're going through right now by talking to your listeners and getting everybody's attention back on the same page to maintain our vigilance and our respect for the drugs, making our commitment to this more visible. I think that sort of in general going to be one of the benefits of this. But I am thinking that with just this activity, number one, but should we find and document some excesses either in certain cancers or in certain adverse health outcomes, such as spontaneous abortion, which has been well documented already by NIOSH in nurses who handle these drugs. I think if the evidence gets better, the temptation for us to cut corners will be less, and that leadership will be more insistent than they currently are, perhaps, about dotting I's and crossing T's. It's just going to help us sort of raise all boats in terms of the way we handle the drugs and our standard operating procedures and respect for the rules.
Well, let's talk a little bit more about the registry itself. So which nurses or other healthcare professionals are eligible to join the registry, and what would qualify someone as having a hazardous drug exposure?
The definition, or in a way, who's eligible to fill out the form, is if you have handled hazardous drugs any time in your working lifetime for at least 1 year, you would be eligible. This would be nurses, nursing assistants, pharmacists, pharm techs, who in our country prepare most of the drug. Believe it or not, veterinary colleagues use the same drugs we do. One can imagine quite precarious situations sometimes. So they're eligible also. You don't have to be still handling drug. You can be a nurse administrator who handled drug routinely 20 years ago, and we'd still like to hear from you. Part of it is because the way some of these drugs act, if you think about carcinogens, you need typically the multi-stage theory of carcinogenesis that we all learned in medical school and nursing school. The hits are multiple. There is a latency involved. It takes a while for the disease to develop. And so it's fine if you haven't handled drug in a while to participate.
Yeah, I always did find that curious. I think I worked at one institution that at one point was trying to set up sort of some routine testing or evaluation to kind of help watch for problems. But I was always a little bit curious. I'm like, well, even if I got exposed today, you're not going to see the problem tomorrow necessarily. Like the short-term CBC is all helpful, I guess. But like to your point, like that latency period and just all the other variables that we know are related to carcinogenesis, like it makes it a difficult web to unweave and to untangle. But we have to start somewhere. And so it sounds like this registry can serve as that sort of foundational data collection point that we might be able to start to use the data that we're collecting in a meaningful way.
I just got back from the ASHP, the American Society of Health Systems Pharmacists meetings where we were talking about this. And to your point about we have to start somewhere, even if things haven't been as vigilant as they should be in your organization, there's no time like the present to start. Somebody said, well, focusing on this might upset people. And my thought would be, or that might upset working people, or they don't want to know. And, this stuff sounds like stuff from the 1950s to me, What I would say is I think that nurses who feel like their organization is trying to protect them by putting all kinds of protections in place, including SOPs and engineering controls and PPE, but also saying, let's go the extra mile as an organization and have everybody complete this registry participation. I would think that that is a sign of committed leadership to the safety and health of their workers. And so I hope it's not something that people would be afraid of.
So in terms of the registry itself, I'm sure understandably, many nurses have concerns about putting their own personal health information in a platform somewhere. So what measures are in place to protect nurses and their own personal or health information and maintaining that confidentiality?
As you might imagine, people in academic medical centers do research for a living. Many of you are on research teams and have done that for your working lifetime. So we're well acquainted with the rules. We've been reviewed by the IRB. They have determined that we do not need IRB approval because people are self-sorting and volunteering to participate. However, as you all probably know, especially if you do research, we still have to show everything to the IRB, everything we do, questionnaires and all of that. It's almost hard to know what they mean by you didn't have to do this, except you still have to show us everything. So I'm sort of making light a little bit of the, I think, quite significant measures we've gone to handle this the way we would any other type of a study, even though we're building a registry that's first just gathering data. So the registry is built on the REDCap platform. It's online. It's a secure, password-protected electronic database. So nobody in your organization is going to know if you participated or not unless you tell them. Your bosses aren't going to find out or anything like that. It's coming straight to the cloud. Also, after your name goes on the first page, you're assigned a number, and all of the subsequent data, the only thing associating an ID with what's on that page is your number. And of course, all of this, the linkages are password protected also. So I think that's pretty much a standard way that most human subjects protected studies are performed. And that's what we used here.
Wonderful. Well, that, again, it's reassuring to hear that this is following all the same rules that any sort of research study that we would be trying to potentially enroll patients in. We're following all of those same rules and safeguards. I think that is reassuring to hear. So thank you for sharing that. So let's just talk through, once someone joins the registry, what does that process involve to join? And then how long does this initial survey take? What does the follow-up look like over time? Essentially, kind of what commitment are nurses signing up for as part of this registry?
Even though this isn't a regular study where you'd have to sign a consent form, the elements of a consent form are on the first page of the registry. So people can access the registry through a link, a hot link, through a QR code. I think we're going to say a little bit more about that at the end of this podcast. ONS has been part of promoting this, as many of you may know. And there is a short video of about 11 minutes that starts at the beginning and introduces everyone to the registry. And it includes me. It includes one of your other colleagues, Dr. Marty Polovich, who's an oncology nurse and has been involved in ONS leadership, promoting, why we do this and sort of reviewing some of the points that I just made during this podcast about the need for this in the absence of a national cancer registry, for example. And then you say, do you want to continue or do you want to participate? And then if you do, you click on another link and it takes you to the first page. It looks like a lot of other health questionnaires you maybe have finished in your doctor's office, except we really emphasize your work history. We take what we call a lifetime occupational history. So we'll ask you to start with your first job, usually after high school or that sort of thing. And we are focusing on jobs where you handled the drug. If you've been at the same organization for your whole practice lifetime, it will be a shorter experience because you are only going to have one job to have to fill out the form for. If you've hopped around, it will be longer. We're estimating about 30 minutes to maybe 45 minutes to fill it out. You can start and stop, and the work will be saved. You don't have to worry about that. I think that in terms of initial surveys, we're thinking probably for at least 3 years, we're going to do just an initial survey. People are already asking us about follow-up surveys. And, we would foresee that makes sense, but it would be several years into the future. We're planning for at least a 20-year horizon so that we will be able to both grow the database on the one hand and be able to follow people forward on the other for longer periods of time. Let me say one more thing that we're proud of, and that is any cancer diagnosis that's self-reported will be validated through the state registries that I just mentioned. So one of the groups on our advisory board is the Maryland Cancer Registry, and they can arrange partnerships with us through the other registries. So I think one of the really kind of robust aspects of the registry will be we will validate self-reported cancer diagnosis.
That's a really important detail to share because, with these types of sort of surveys and self-report, it's only as good as the accuracy of the data being provided. And so that's an important validation step. So thank you for mentioning that. What would you say maybe are some of the tangible benefits that nurses might receive or might feel from participating in this registry?
It's interesting that you said might feel. I think that this is something you do not just for yourself, but for your colleagues. We talk about this issue of potential hazard or, have we been exposed in a serious way or this sort of thing. And I think this is sort of a tangible activity that members can participate in to make you feel like you're doing something or you're committed enough to do this, at least do this. I get phone calls probably once a month from an oncology nurse or pharmacist who's calling with a sad story. Usually it's a health outcome connected to, and people have not been vigilant or our leadership scoffs at this or et cetera, ... And this could be one thing that you can actually do that's tangible to say to yourself and to your colleagues, I'm serious enough about this to spend 30 or 45 minutes contributing to this database. So maybe some of these questions can be answered more clearly.
It's not unlike other phases of research where people enroll in those studies, not because they might not perceive the actual benefit of that study or have their outcome changed, but it helps build that information, that knowledge base to, potentially impact people in the future. So, we as nurses are asked to be selfless a lot, and that is part of the job. But you're absolutely right. In this situation, exposure to hazardous drugs is rarely contained to a single person at a single event. It is that sort of slow drip of exposure potentially over the long term. And so even if you don't have concerns about your own health, I remember hearing a lovely colleague who once said, I'm old, I don't care what happens to me. Well, okay, that's your right to feel that way. But exposure is not something that you can contain to only impacting yourself. If you're exposed, then the surfaces that you potentially touch are sharing and spreading that exposure. And so, this is an investment in your own health and understanding what are the risks that you're taking on. But as you mentioned, this is something that we do for each other because we're working in a shared space. We're working towards a common goal, but we have to kind of work together to protect each other as well.
I think it's interesting that you said what a senior nurse said. Actually, a senior nurse said to me, who has me come and give a talk somewhere locally here, every other year. So she said, I'm worried about the young ones because they don't seem to understand what's going on here. I'm paraphrasing. In other words, maybe they didn't come through with the same respect. I don't mean fear, I mean respect for what we're handling. It's interesting. And also I want to capitalize on, Jaime, what you just said about, drip, drip, no pun intended, but it's very easy in the sort of life cycle of a drug in an organization to do something that doesn't just impact you, but unknowingly you've contaminated a surface or something for somebody who comes behind you, who doesn't maybe have PPE on because something that got contaminated shouldn't have been contaminated in the first place. In one of my very first studies, I was supervising a master's student at Hopkins, and he wanted to do wipe sampling. And I took him over to the oncology outpatient clinic, and he was working primarily wipe sampling in the hood, but then just watching the pharmacist preparing drug. And this is appropriate for nurses too, because there's plenty of places where nurses prepare drug, as you guys well know. And the phones were contaminated because the pharmacist is taking a gloved hand out of the BSC and answering the phone. And so the next person who comes to answer the phone wouldn't think to have a glove on. I'm just saying that if we could all be thinking of it more as a sort of a team sport, that especially in terms of safe handling, that our disposition in drug handling affects not just us and our health, but those of our colleagues as well.
Let's talk just briefly about how do you envision the data being collected and what will happen to it over the next 10 or 20 years? And could it potentially influence clinical practice or even help, ideally, maybe influence some national safety standards?
To your point about safety standards, one of the first sort of big observations could come if we don't see much. Maybe then the impression is that the current safety guidance we have is working and is being performed enough, even though we know it's not perfect. Or if we see concerning excesses of certain kinds of abnormalities, that's a feedback piece of data that what we have in place maybe isn't good enough. Not that I know what it would look like otherwise, although one of the first things I say when people say, well, what more would you add? I think I'd say before I add more, I'd make sure people are getting religion about doing what we already say we're supposed to do right. And I know that's not happening. From that point of view, I think there could be this sort of feedback that could ultimately influence practice or could, like I said, at least get people to maintain their vigilance when they handle these agents, rather than there necessarily having to be some change or increase in handling guidance or additions. I hope that we don't have to wait super long. I have told people on our advisory board, I would hope we would have a first paper or report after, like, let's say 3 years or so. We'd like to have several thousand people complete the survey before we start. And even in the beginning, we can just describe demographics and who did hear the call and who is uptaking and taking on doing this survey. The other thing that might be of interest to the folks who are listening is for each of the job history pieces, we ask, for example, what year you started, what year you stopped, and we ask about estimations of handling. So we'll get a feeling for, be able to come up with either duration or some kind of metric for the intensity and duration of your handling history, which will then permit us to sort the population who completed the survey into sort of low, medium, high. And we'll see whether the health outcomes that are being reported are influenced by that drug handling history. For you epidemiologists out there, we ask a lot of other questions, for example, about other known carcinogenic exposures that could explain an increased cancer risk. So we'll be able to control for that. Ultimately, though, we'd like to know whether some of these concerns for what is currently invisible that we're not able to link to occupation, if there is a cancer excess, we want to know about it. And we would, obviously report that. I would hope that would have some kind of a ripple effect, both at the facility level in terms of increases in safety culture and people following the rules, or even then huddling about whether the rules are sufficient, which would be probably a policy issue.
Well, and it sounds like the key to finding all this information out as quickly as possible is to have as many people join the registry as we can get. And the sooner the better to get that pool of data available for you and your team to start analyzing. So what challenges do you anticipate in getting nurses to register? Or are there any strategies you're considering to help overcome some of those barriers?
I would say the same thing, ask the same question of the people listening. Obviously, this is not something you fill out in 5 minutes, and it does take a plan for you to give 30 minutes or slightly more to doing it. And like I said, you don't have to do it all in one time, but I think that's the only major hurdle. On the other hand, we've heard of the great successes of the Harvard nurses study, and I've looked at their questionnaires and they're very, very long. Nurses committed to be part of that study, and I'm really hoping oncology nurses and nursing assistants would commit to be part of this because it's for their own community. Maybe, and if you have a good experience or your ONS local chapter decides to do something where they invite everybody to come and bring their laptop one night and everybody does it together. By that, I mean in the same period of time. If you come up with a success story, please let us know, because I think that's the only really barrier to this is that it does take time.
As a nurse leader, I would look for opportunities for those that are, again, not coercing anybody to join if they are not wanting to, but if people who want that, if there's a way to, allow for time and provide coverage while they're on the unit to let people step away for the 30 or 45 minutes. I know that's probably laughable for saying out loud in terms of finding time to give nurses that break, but what a wonderful gift that could be to just allow nurses to use that time while they're on the work to also prioritize their own health and safety. So I agree. If there are ideas or great ways that nurses have seen to be able to find that time or encourage their colleagues to join in, we welcome those discussions on our ONS communities of just ways that we can share this more broadly and invite people to creatively find ways to prioritize this for themselves and for their teammates.
I agree. Let me share one more thing. A nurse leader told me she was considering having completing the registry be part of one of the competencies for her team. So just any kinds of ideas where we can incentivize people to participate is what we're interested in. And so if you've got one, please let us know.
Absolutely. The sooner in a career a nurse joins this registry and we can actually start to follow people from the beginning, if they have those exposures or those concerns, I think the sooner people are registering and with the long-term goal of following them, as you said, over time to see if we're seeing anything happen, I think the sooner and more consistently we get people to join, the better.
Agreed.
So which professional organizations or other nursing bodies are partnering with the registry, and how do those collaborations help to amplify its impact?
So obviously, as I mentioned, ONS is on our advisory board, and some of your members have been personal friends for years, have been thinking about this for years with us. So we're grateful for that. ASHP is also American Society of Health Systems Pharmacists, very involved. Happily, the ANA just joined us this year, and they have a sort of a health awareness campaign going on in their members and are going to promote participation in the registry kind of through that avenue, which I'm very happy for. HOPA, the Hematology Oncology Pharmacy Association, has someone on our advisory board also. So I think the major players in oncology practice are involved, and that has helped us come this far and also informed the construction of the questionnaire and the piloting of it. They've all participated in that if they had been at some time in their working lifetime a hazardous drug handling oncology worker.
Outstanding. Well, Melissa, thanks so much for joining us on the podcast today. We're going to close things out with a series of quick questions. But before we get to that, I did want to just mention and reassure where our listeners can find this information on our website. So if you go to ons.org, we have a brief information and a link to the registry. It is in our learning library section. It's in the Safe Handling of Hazardous Drugs learning library. So if you find that on our website, we do have a link. I think it's towards the bottom of the page. There's a little kind of accordion that will expand, and you can find a little bit more information and a direct link there. We'll also include a link in the episode notes of this podcast today. So a couple of quick ways to find it, because everything we're talking about today, what we really want to come of this is to get you to that link so you can learn more and hopefully join the registry if that feels like the right decision for you. So as we get to the end, let's run through a series of quick questions just to help summarize some of the things we've talked about. How do you think healthcare professionals can evaluate their own hidden or maybe their implicit bias that they might hold just about hazardous drug handling?
The implicit bias goes back to something you already mentioned too, Jaime, about we sacrifice ourselves for our patients. And that would be something else I would just ask everybody to sort of examine. We don't have to make an either or choice. We can take competent, compassionate care of our patients and still do our job safely. Those would be areas I would say we should sort of examine our consciences around, if you would, regarding our biases.
What are some common misconceptions about hazardous drug exposure?
I've had people, not nurses, but other people who handle the drug say, air quotes, it's just a little bit. My colleagues know that's something that kind of sets me off.
Grind your gears a little bit.
Yeah. I mean, not in public, but you just shake your head. I would say that the idea that we aren't exposed to the same therapeutic dose we give to our patients is absolutely true. However, the dosing schedule to them versus us is very different. And we are exposed frequently, if not daily, to very small concentrations. They don't reach a cytotoxic dose necessarily. But we do know from a lot of the studies that have been done that either we or our colleagues are taking up drug from contaminated work environments. And you've probably seen there's an awful lot of intermediate evidence looking at genotoxic insult in pharmacists and nurses who handle the drugs. So we're showing uptake, and we are showing that there are biologically plausible, concerning measures that are taking place in us. And so I think that we need to come back and circle around the idea that we need to have deep respect for the toxicity of these agents.
What's something about this topic that's not often discussed, but you wish people knew more about?
Something we didn't talk about at all today, but if we had more time, would be the biologics. And by that, I mean monoclonal antibodies, TK inhibitors, all of the IBs and the ABs, and historically the non-genotoxic newer drugs that we all thought were going to be this great godsend, which of course it has to patients, but we were told that they wouldn't be toxic. And it's turning out that's not quite the case. And it's also turning out that their large molecular weight doesn't necessarily save us from having to be concerned about their hazards. So since that's a quick teaser, but I would say to your colleagues, a number of biologics are on the NIOSH list, and a number have been put on that list by their own manufacturers. So that's my quick little sermonette on that.
What additional training do you think oncology nurses need to stay current on this topic?
I would say you might want to take a look at the NIOSH alert from last year, the November, December 2024. Unfortunately, NIOSH suffered a lot of downsizing this year and, unclear what's going to happen in the future there. But there's some really useful information in there, not just lists, but some of the thought process that went into decisions about keeping something on or off the list. For those of you that might have some interest in how those decisions are made, I would suggest that.
And are there any additional resources you'd recommend for patients or maybe other types of providers who want to learn more?
I tend not to work specifically with the patients. I tend to work more with workers who handle drug. I would say that obviously the patients need these therapeutic agents for their own protection against the disease. And I guess the risk-benefit calculus for these drugs for a patient is so very different than it is for us. And so I think that's something that we would like to maybe think a little bit more about together. That's kind of what makes this a different situation for workers than for patients.
Yeah, and I think what we can learn from this registry and focusing on healthcare providers, does this eventually translate into the education that we provide to patients and their caregivers? How do they keep their home environment safe?
Exactly.
I think there's, as you said, it will rise all the boats. If we can learn more about what is the true risk and where does that risk occur, we can implement what needs to change, if anything, in all these different environments. So absolutely great thoughts there. Melissa, thank you again so much for joining us and sharing all of the great work that you've done to set up this registry and share all of the potential benefits. I hope our listeners have learned something and are excited to learn more and hopefully join that registry. Do you have any final comments to share with our listeners today?
I thank you for your time and attention, everyone. And please, if you would, make a promise to yourself, if you're so inclined, to complete the registry survey. It's probably a good way to start off the new year.
Wonderful. Well, thank you again.
Thank you, too.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.